We're going to move down from the ankle into the foot. We'll talk a little bit about advanced imaging of subtle and complex injuries. We'll deal with talus injuries. We talked about osteochondral injuries and OCDs in the foot talk. We'll spend some time talking about talus body fractures, talar neck fractures, talar process fractures. We'll spend some time on calcaneus fractures, and we'll finish up with midfoot fractures. And again, the theme is similar. It is a temptation to say, oh, that's a nasty fracture of the foot, and stop, because they're usually a mess when they're positive. There is a little bit to talk about that'll improve how well you can give the emergency physicians information for reporting back to the orthopedic surgeons, and there are some tricks and tips for CT scanning and or MRI scanning. In terms of the talus, once you get past the osteochondral lesion of the dome, talar neck fractures are uncommon but devastating, and depending upon where you're at, you might see more, you might see fewer. They tend to occur right at the neck, and they are classified according to the Hawkins classification, which is a classification that is widely used in the orthopedic world. A type 1 fracture is undisplaced, and that is a tolerance of less than 1 millimeter. They truly have to be undisplaced to be a Hawkins 1. Type 2 is displaced, and then with that comes some subtalar subluxation. A type 3, which was a modification to the original classification, was added by Hawkins in 1970, and that adds tibiotalar dislocation, where you kind of squirt the head of the talus out into the soft tissues posterolaterally. And then Canali and Kelly, which are a couple of other orthopedic surgeons who have written quite a bit in the trauma world, added talonavicular dislocation as the last type of a talus neck fracture. The reason this matters is that the talus is much alike to the scaphoid in the wrist. It has an awful lot of cartilage on it, and it can only get blood supply into it from a couple of places, through the neck, through the sinus tarsi. And so fractures that go through basically the waist of the navicular, if you will, and are displaced have a higher likelihood of osteonecrosis. And in the foot, osteonecrosis of the talus is a bad thing. The fracture itself will eventually heal almost always. The secondary osteoarthritis at the ankle that happens is profound and usually leads to hindfoot arthrodesis within about 5 years. People have tried doing ankle arthroplasties, but when the bone is dead to begin with, it doesn't work out all that well. Now here's one interesting point. Radiologists usually refer to signs as something we see that tells us there's something wrong. And in the orthopedic world, Hawkins said, I'm going to talk about this sign that says that all is right in the world, and if you have intact blood supply to the talus that has been immobilized in the setting of trauma, osteopenia will create a subchondral lucent crescent, tracking along the undersurface of the talus at the tide mark, just tracking right along here where the arrows are. So if you see this, it indicates that the blood supply is intact. So if you want to make the possibility of osteonecrosis because it is sclerotic all the way across, what you need to say is that there is absence of a Hawkins sign, there is subchondral sclerosis, and therefore there is the risk of osteonecrosis. And that's just a little thing that is different. We would have come up with a sign that said it's sclerotic, therefore it's the sclerotic talus sign or something like that. Now, talar body fractures are a little bit different. They are harder to see than talar neck fractures. They're beyond the osteochondral injuries. They tend to be high energy, shearing injuries, and they are the cousin, the pilon or pilon fractures in the distal tibia. If you impact the talus against the tibia and it's a high enough energy deposition rate, the talus body can shatter. You end up with shearing injuries in either the coronal, sagittal, or horizontal plane. You can end up with isolated posterior process fractures, which are a lower energy injury, lateral process fractures, which we will talk about, and crush fractures. Sneppen wrote the classification that is used. I don't use this classification in real life. I simply point out that there's a talus body fracture, and that usually gets the orthopods appropriately energized to come look at the patient. Here we have a patient with a Tilo fracture. That's the first thing that you see, and you go, okay, that's pretty interesting. If you look a little longer, you see that there's a vertical step off in the lateral junction of the talar dome, and you go, it's kind of the opposite of an osteochondral defect. And then if you look and start to put on your hallucination glasses, there's some oblique lucent component through the talus. And when you look, here is the axial CT image showing the Tilot-type fracture at the tibial tubercle, but in fact there is a shearing complex multiplane fracture going through the talar body. Here is a second patient, which is just frightening because, you know, you pop this up and there's just nothing wrong there. I mean, it's not the prettiest picture, but if you were reading these in the emergency room, I think I would call that normal. I think that, you know, just when you look at it and then you look on the lateral view and it's kind of a bright image and boy, there isn't much there. Maybe if you're knowing that I'm showing it at a conference, you say there's something strange right here. And then when you get a CT scan, you go, holy mackerel. And that's a comminuted fracture. This one has both coronal and sagittal plane fractures. There's severe comminution through the posterior facet of the subtalar joint. And then this is a second patient with a similar type of injury, and it shows you how you can end up with very complicated fractures. And if you look, we have this smoothly marginated edge of bone which has subchondral condensation. This is, in fact, the undersurface of the talus, the posterior facet of the subtalar joint from the talus side, and it has been rotated 90 degrees to the back and is out of place. So this talus is not going to do well. The risk of osteonecrosis is sky high here. The long-term consequences will be difficult, and fixing this will be extremely difficult because there's no place that's not cartilaginous to put it all back together. When you look at it in the sagittal plane, kind of a composite image, as you walk through, you can see that you start to get comminution, and then you get this large slice image that just shows that the posterior facet of the subtalar joint has been beaten up pretty severely, and there's comminution coming all the way across. So there's more risk of osteonecrosis with talar body fractures than even with talar neck fractures. They are difficult to diagnose. Now, lateral process fractures of the talus were exceedingly uncommon prior to snowboarding. They are now actually kind of common. Hawkins, who has a clinic at Vail, started to classify these because he happened to be in a unique position to be treating patients who had snowboarder injuries because he was right at the base of the mountain. They are classified in yet the familiar sort of not badly broken to really badly broken type 1, 2, and 3. And the unique reason for the Snowboard Association, I'm not sure of. There has been some work on it. The boots that the snowboarders use will have more flexibility than ski boots. It's a fixed position, foot on the board, and I think anyone who has done skiing and or snowboarding, we were talking about it at a conference last week. I think there's more mobility and you can end up with the talus fracture in snowboarding, whereas with the skiing, you rigidly fix the foot to the ski so you protect the ankle at the sacrifice of the MCL. You know, for anyone who's a skier, the MCL is kind of the thing you're always worrying about. And in the snowboarders, there's more mobility in the foot with the boots that they use. Now, here's a lateral process fracture, and these also are difficult to see. There is some irregularity in the region of the lateral process on the AP view. When you go to the mortise image, it becomes obscured. Maybe there's a little bit of irregularity there, but I wouldn't say that that's an obvious finding whatsoever. And it is extraordinarily difficult to see the lateral process on a lateral view of the ankle. It just is very difficult. In retrospect, there may be some extra densities in there, but it really is not easy to see. When you get the CT scan to look for it, you can see that this is a comminuted, large articular component type 3 fracture of the lateral process of the talus. Now we're going to shift gears and talk about calcaneal fractures. These are common. You, without a doubt, if you work in an emergency room, come across them. They are from a fall of a height or in motor vehicle accidents. There is radiographic assessment, and anymore there is an awful lot of CT scan assessment to evaluate these. We all learned at one point that Bowler's angle is normal between 25 and 40, and I'll show you an example of that, and that if it is flattened, there is a likelihood that there is a fracture. The orthopedic surgeons use a completely different radiographic structure. It's called the crucial angle of Gisson. I'll show you that on the diagram on the next one. This is from the sustentaculum talus. It's the undersurface of the sustentaculum, and when you get an ankle fracture that involves the body of the ankle, the sustentaculum is usually fractured off and rotated slightly, and this condensation of bone that shows up as an angle disappears. So in Bowler's angle, it gets flattened. The crucial angle of Gisson gets erased or obscured. And then we're going to talk a little bit about a portion of the calcaneus called the thalamic portion. This is another one of those points where if you use the thalamus of the calcaneus, the orthopods use that terminology. It's not something that was ever taught in radiology residency. It's just a surgical term that they use for a particular portion of the calcaneus. So if you look at the orthopedic literature, they note Bowler's angle, which is the tip of the anterior process of the calcaneus to the highest portion of the posterior facet of the subtalar joint to the tibial tubercle posteriorly. That angle should be between 20 and 40 degrees. If it gets flattened, there's a risk that there's a calcaneal fracture. The crucial angle of Guisan is this inverted V that tracks along the medial aspect of the, well, it's formed by medial structures of the calcaneus, and it is the undersurface of the sustentaculum tali. The thalamic portion of the talus is this portion here, the portion of the os calcis that is deep to the posterior facet of the subtalar joint in this location. Fractures tend to beat this area up, lead to articular incongruity, and that is a predictor for osteoarthritis in patients who have calcaneal fractures. Now, mechanism of injury is usually a fall from a height or a twisting injury. Fractures are, for the most part, intraarticular, and that almost always means the posterior facet of the subtalar joint is involved, with possible also involvement of the middle facet of the subtalar joint and the calcaneocuboid joint. The intraarticular fractures are from axial loading. Again, you have the talus driving down into the calcaneus, assuming that the ankle joint and or the talus itself do not fail. It's more of the same sort of an axial load forced transduction, which piece of the lower extremity failed. The extraarticular injuries tend to be twisting, tend to be smaller fractures, tend to be process fractures, and I'll show you a couple of those. Now, with intraarticular os calcis fractures, there are associated injuries between 6 and 70%, depending upon which series you look at. Spine injuries are the ones that you always think about. Somebody fell from a height. You look for a thoracolumbar burst fracture. Lower extremity injuries are common because the amount of energy required is fairly high, and so you can get knee injuries, ankle injuries. You don't normally see hip dislocations, things like that, but that's all possible. 5 to 9% of the time it's bilateral, and that has mostly to do with how the patient landed when they suffered the injury. Now, like everything in the world, there are classifications present, and this is another one where I describe the findings, but I do not use the classifications because the one that the orthopods use is a little bit too complicated. The original is the Essex-Lopresti, and this is the one that is in Lee Rogers' books and in all of the trauma books for radiology, talking about tongue type and joint depression. And I will use that terminology when I talk about them, but I don't go into classification beyond that. Crosby and Fitzgibbons had a nice classification along the 3-category standpoint, but the classification that almost everybody uses in the ortho world is the Sanders classification, and I'll show that too. So the Essex-Lopresti is what we've been taught when you're getting ready for boards. Extraarticular with the anterior process, tuberosity, medial process, isolated sustentaculum. The intraarticular come in 2 flavors, the tongue type and the joint depression. Crosby and Fitzgibbons are the variations of the 3 types of fractures, not so bad, sort of bad, really bad. And now with intraarticular calcaneal fractures, there are 2 fracture lines usually. The initial fracture line goes from plantar medial to dorsolateral. It's sort of an oblique fracture through the body. It leads you with a fracture that includes the sustentaculum, and then a second fracture that includes the other side, a posterolateral fragment. The secondary fracture line can have 2 main varieties: a tongue type, a large piece of bone out the back of the os calcis, or a comminuted fracture involving the thalamic portion of the calcaneus. The reason this was useful way back when was that with a tongue type fracture, here's the example, the primary fracture line runs down through the body. The secondary fracture line can either be limited to the thalamic portion of the os calcis. This would be the intraarticular fracture of the joint depression variety. Here you can have a fracture line that goes back, and this is called a tongue-type fracture. And you see that when the displacement occurs, the posterior facet becomes incongruent, but as a large piece. This has historical value because back before surgical techniques improved, you could run a stove bolt into the back of the os calcis here, right percutaneously, and if it was a long enough stove bolt, you could cam this into position, getting a somewhat better reduction, and then cast the patient without internal fixation. This is 20, 25 years ago. Nowadays, they internally fix the vast majority of these if there's displacement, so the differentiation between this fracture type and this fracture type is less significant. There's the thalamic portion again. Now, the Sanders classification refers to the number of fracture lines that involve the posterior facet of the subtalar joint, whether or not they are comminuted or depressed, and then within each classification is the fracture line sustentacular, medial, central, or lateral. Now, there's lots and lots of classifications there, and it's an A, B, and C system that has a bunch of subtypes. You end up with an overly complicated system, and what I end up doing is looking at the number of fracture lines that are there, and then I just simply talk about the fracture lines that are present. And we'll talk about those. Now, the second thing that happens with calcaneal fractures in a clinical sort of standpoint is that when you smash the os calcis, you end up with widening of the hind foot, and there's foreshortening of the AP dimension of the os calcis. And you'll hear people talk about a wide, short, flat hind foot. And that's the clinical appearance, and we find that on CT scans. With CT, it's very common to do CT, and almost all of our calcaneal fractures get a CT scan now. I don't normally, I just say there's an comminuted os calcis fracture, and it's almost automatic, whether it happens that night out of the emergency room or whether it's done as an outpatient, but they don't fix calcaneal fractures or even make the decision whether or not to fix them without a CT scan. In the old days, we used to do directly acquired oblique, coronal, and oblique axial acquisitions, but anymore with the modern multi-slice scanners, you can pretty much just put a patient into the CT scanner, acquire an axial data set at very thin slices, and then reconstruct them pretty much however you want. The way that I reconstruct is the original axial formats, because that will show me any fractures through the calcaneal cuboid joint, which is out in front, and then I will do an oblique coronal image, which shows me the posterior facet of the subtalar joint to advantage, because you want to see those fracture lines to understand whether or not there's articular incongruity right there. Just a summary, the Sanders classification, very complicated, 1, 2, 3, and 4. I just talk about how many fracture lines are there. So here's an example. We have a calcaneal fracture. Bowler's angle is narrowed, it's flattened. There is extra density in here, and the crucial angle of Gisson is absent. It's just not present. You can see there's a fracture line in there. The severity is not well delineated. Here's a second patient, similar sort of fracture. The old os calcis view on the right is, for the most part, not very useful. We just don't see, you know, I see it, I see there's a fracture, but in terms of deciding how much information needs to be conveyed to the surgeon, we don't get it. Here's an example of the old oblique coronal images, which did the best to go perpendicular to the posterior facet of the subtalar joint, and these images were taken to be roughly parallel to the long axis or along the calcaneal cuboid joint. Anymore now, you just acquire the images and you can slice and dice it however you want. So here we have a calcaneal joint depression fracture. This is the comminution within the body of the os calcis. We are below or plantar to the actual joint itself, showing the comminution here, and the calcaneus will foreshorten in the front to back dimension and become wider than normal. When you get up toward the subtalar joint, here is a sustentacular fragment in the Sanders sort of classification, and this particular fracture is not displaced. It's a single fracture line that starts right at the base of the sustentaculum and heads back. This is about the simplest calcaneal fracture you're going to come across. Now, in the more comminuted, and this particular patient, we did a 3D surface shaded display to show the sustentacular fragment was fractured off of the medial side of the joint. Here is a more comminuted fracture, better demonstrating how the calcaneus becomes foreshortened from front to back. It really should be a centimeter or so longer. It has become wider, and if you look at this foot, you end up with this kind of chubby posterior hind foot. And then when you look at the subtalar joint, you see that there's not only, there's the one fracture line here, but it splits into two, and the two components are splayed from each other. This needs to be surgically fixed. Another example showing two fracture lines through the central and lateral aspect of the os calcis, as well as a third fracture through the sustentacular component. So if you're a classification maven, this would be a type 4. I would instead simply describe those and say that the resultant incongruity of the posterior facet of the subtalar joint is significant. Now, here are a couple of examples showing extraarticular fractures, and that's under the Essex-Lopresti classification, when in fact I don't like that because this is clearly an articular fracture. It involves the calcaneocuboid joint. Anterior process fractures of the os calcis can be tough to see. The patients will not go away. They will have persistent pain. They will come back and come back and come back until somebody finally gets a bone scan or a CT, and then they will find the fracture, and then they will go back and look at all of the prior plane films with a magnifying glass, and they will see the fracture hiding in there. So just be aware that this is a hot, it's not a common spot, but it is a possible place for a fracture to show up. Here, there are two mechanisms for getting an anterior process fracture. You can end up with a nutcracker fracture where you impact it, and here you see the fracture line, not so bad. If you look at the left-sided image where it's not plantar flexed but simply neutral to dorsiflexed, that's an extraordinarily difficult fracture to see. I mean, it's there now that I'm pointing a white arrow at it and massaging the arrow back and forth, but that's a hard fracture to see. This one we happened to get lucky, and they did a plantar flexion view because this person happened to be a dancer, and you go, oh yeah, now it's pretty obvious, but these can be tough. When you blow it up, it even gets more obvious, and that just only happens when you're giving conferences or discussing it with other people. Here is a very difficult fracture to see, a small corticated fragment that has come off. This was a subacute presentation, and this is the other reason why calcaneal anterior process fractures can happen. It's called the bifurcate ligament avulsion, and there is a ligament that runs from the calcaneus. It originates on the anterior process of the os calcis and extends both to the navicular and to the cuboid and is called the bifurcate ligament. And so you can end up with an avulsion that is because of the bifurcate ligament, and when you do a CT on this patient, it is a small avulsive type component with the portion of the ligament running here to the navicular and the second portion running deeper and more distal to the cuboid. Now the next topic that I want to talk about is a cousin to Liz Franc, which we will follow with. Midfoot hyperflexion injuries are difficult. They are just flat out difficult. When you fall down on a plantar flexed foot, or the best analogy is you are dragging your feet off of the front of a, I don't know, bulldozer is the example that comes to mind because I had a patient that had that. You're riding on the front of a four-wheeler, and you're dragging your feet along, and all of a sudden you get your foot caught, and it gets jammed from a plantar flexed position. You end up camming through the midfoot, and you can get significant injury, and the radiographs are extremely subtle. The radiographs underestimate the number of injuries. It is an unstable injury, much like a Liz Franc injury, which we'll talk about in a second. CT imaging is the way to go. Radiographs will miss clinically significant injuries. You know, if I had my druthers, I would probably skip. I would do radiographs, but if the radiographs were negative, I would do CT if there was significant swelling and difficulty with walking. And I think if I had to choose between one or the other, I would do CT over plain film with enough swelling and with a mechanism, because the plain films are notoriously undercalling of injuries, and this is a big deal. MRI is an excellent way to see the injuries, but in terms of the cortical step-offs, where the surgeons are going to put their K-wires for fixation, CT just gives better information. Now the next talk that I want to talk about is Liz Franc fracture dislocation. This is normal. You're looking at it going, what's wrong here? I just put this one up as an example to show how Liz Franc's ligament is a very strong ligament, and once you start doing MR, you'll see it when you look for it. It runs from the undersurface of the lateral aspect of the medial cuneiform, extending to the medial edge of the base of the second metatarsal. It is a pinion that holds the second metatarsal in the recessed articulation of the short middle cuneiform, and with that, all of the other ligaments are pinioned off of this. The hallux TMT joint is a weak joint. All of the rest of the tarsometatarsal joints are relatively weak compared to Liz Franc's, and the intermetatarsal ligaments are fairly strong. So if you blow this ligament, you can slide all of these off laterally. And here is an example. This is a normal for reference, and here is an abnormal. And you see that there is increased gap between the first and second metatarsals. The cue that I use, the clue, is I look at the medial edge of the middle cuneiform, and it should line up exactly with the medial edge of the second metatarsal. There's an example. This is an exact alignment. This has lateral subluxation. Without a doubt, there are additional fractures in the midfoot here that we don't see. Another example, nice alignment on the right, abnormal step-off on the left, and in this particular patient, there was avulsion of the bony attachment on the second metatarsal, and the Lisfranc ligament itself is still attached to this piece of bone and going back over to the medial cuneiform. When you do a CT, you always find extra fractures. So not only is there a fracture here, but you see there's comminuted fractures through the second, the third, and the fourth metatarsal bases. The last thing I want to talk about is an uncommon injury. It's not got much clinical significance, but you will see it. Once I started looking for it, I went, isn't that cute? It shows up all the time. There is a little flake avulsion that comes off of the lateral aspect of the calcaneus, and it is right here. You can see this injury here, and it kind of sits out in the middle of nowhere. You could mistake it for an os perineum, but if you go back and look, and it only has one article that talked about it. It happened to be Lee Rogers was involved in that, and they did a series, and they found that 10% in theirs. Now, that's a selection bias without a doubt, because if you think about it, we don't see it that often, but you will see it when you look for it. And it is an avulsion of the muscle attachment of extensor digitorum brevis. If you want to throw that in there, they'll go, oh, isn't that cute? And that's an interesting sort of thing. So in summary, there are foot structures that are at risk in trauma, particularly at the talus and through the midfoot. The calcaneal fractures are common, complicated, and have a high imaging component in their disposition prior to decision on whether or not to have surgery. And we do play a pretty pivotal role, not only in detecting, but in helping to stratify the patients.